All right, good evening. My name is Kyle Megatelli. I am the social media and webinar coordinator for Student Doctor Network. And I want to welcome everyone to our Developmental Behavioral Pediatrics, The Secret No More webinar. So we're very lucky to have Dr. Damon Korb and Dr. Neelkamal Soares with us this evening. And before we get started with that, I wanted to talk a little bit about Student Doctor Network. So SDN, here's basic overview of our resources. If you haven't been on Student Doctor Network, studentdoctor.net, just hop on there. It's a lot better to go on there and poke around than me trying to tell you about it, because there is a lot of resources. We're focused on making sure that every student has the opportunity to attend health professional school. So our community, we're best known for the forums. There is hundreds of thousands of users. I sometimes try to cite a number. I always undershoot it by a lot. So we have communities for medicine, audiology, dentistry. You guys can read it. Confidential expert advice. This is an extremely useful forum. If you have a question about something and you need, if you need no BS answers, hop on there. You are going to find out what you need. I've used it myself multiple times. The pre-med planner app. This is a good one. Are you a pre-med? You're looking to go to med school? Hop on the Apple or Google store. Get this. It will help you organize everything you need to do from day one to when you're dropping your apps. The hour tracker, very, very, very useful. You definitely want to make sure that you're not trying to do that in your head when you're going through your clinicals. And if you want to see us on social media, find out what we're up to, you can stay up to date on informational webinars like these, informative news, anything and everything. Hop onto our socials. And that is more than enough out of me. I would like to, again, introduce Dr. Damon Korb, Dr. Neelkamal Soares. Gentlemen, if you could tell us a little bit about yourselves, please.
Okay, I'll go first. Let's see. I'm a developmental behavioral pediatrician. I direct a clinic in Los Gatos, California called the Center for Developing Minds. I am an author. I wrote a book called Raising an Organized Child. I have an academic appointment through Stanford Children's Hospital, and we see complex kids with a whole range of developmental issues.
Great, and I'm Neil Soares. I'm a developmental behavioral pediatrician. I'm a professor of pediatric and adolescent medicine at Western Michigan University Homo Stryker School of Medicine in Kalamazoo, Michigan. I'm predominantly an academician, apart from seeing patients, a lot like Dr. Korb. I do a lot of teaching, informal teaching in the clinic, some didactic teaching for the medical school, including I participate in some of the neurology sort of team-based learning courses, and I enjoy having medical students with me. I do a lot of research with them, research projects involving my specialty, but also things with the electronic health record. And another thing, like Dr. Korb, I'm heavily involved in advocacy at both a national and a regional level, and that is an important thing, as you'll come to know. So I've got multiple roles and I enjoy them all.
Excellent, thank you. And for all the viewers, please submit your comments and questions, and we'll get those answered as best we can. So first off, I know nothing about developmental behavioral pediatrics. Can you please tell us about this specialty?
Sure. So it is a specialty that's been around for 50 plus years, but really it was been recognized by the American Board of Pediatrics for the last 20 years in 2002. And it is a subspecialty training that occurs after your primary specialty training, which in most cases is pediatrics, though in some cases there are people who do medicine pediatrics residencies who might want to do a fellowship. It's a 3-year fellowship, and part of the reason it is a 3-year fellowship is because the Board of Pediatrics deemed it's necessary to have a rounded education, including research and academics in addition to the clinical pieces. It's similar to other subspecialties. So if you wanted to go to pediatric cardiology or pediatric pulmonology, there's also 3 years following your residency. It is a board specialization, so it's a standalone sort of subspecialty board. You have to keep renewing your board certification every 10 years or so. It's very interesting, and we'll talk about that later in terms of what you can practice, how you can practice, and where you can practice. But I will leave you with one simple thing. It is the greatest job security in the field that you can ever find, because there are always more jobs than there are candidates, and there are always more fellowship training opportunities than there are candidates. So there is never a situation where a developmental behavioral pediatrician is not courted by multiple employers and multiple organizations.
Okay.
Dr. Korb?
I think you said it all. I mean, I think that defines our field really well. I think when we go through our slideshow a little bit, I can tell you a little bit more about how we practice and how we do things. But I'm 100% agreement, Neil.
Okay, excellent. So what is it that attracted you to this specialty?
Well, let me start there. Let me tell you a little bit about my background. So when I was in college, I did a lot of community service. I was a big brother for a little boy. I was I taught in a elementary school class. I ran track and field events for kids with disabilities, and so I had this huge community service, child developmental delay background. And I went to medical school, never hearing about this specialty. I'd never heard of it. I was going to be the best pediatric surgeon around. And shortly after going there, I met a developmental behavioral pediatrician. We were doing just rounding in pediatrics. And he walked us all into the room, all the medical students, and he said, "Tell me how old this child is by observing this child." And I just thought that was so. First of all, we were terrible at it. I mean, we were off. We like twice. An 8-month-old were like 16 months, and we were 100% off on things. And what I thought was really cool, though, is the clues that we could look at, what I call observable phenomenon. These things that we can tease out in children to really understand what's going on in their brain. And to me, that was the exciting part of this field. That, even though then I didn't know that's what I was going to be, each step got me closer. I decided pediatrics. And when I was in pediatrics, I was looking at adolescent medicine versus developmental pediatrics. And I just kept moving closer and closer. And knowing what I started with and my background in with children and kids with disabilities, it's the perfect specialty. It was a home run.
That's interesting, Damon. I come from a slightly different perspective. So I am a foreign medical graduate. I did my med school training in India. And a lot like Damon, I had very subliminal connection with developmental behavioral peds, and I never knew it. My aunt used to run a school for children with special needs. And I used to visit there, and I found her work interesting, but it never clicked in my mind. And I really wanted to be a pediatric hematologist oncologist. In fact, I came to the United States to seek pediatric residency and then hem-onc training. And I was committed to that. I reached my second year of residency, A, not knowing about developmental behavioral pediatrics, and B, committed to being a hematologist oncologist. And then in my second year of peds residency, just as it's time to start sending out applications, I had this very fortuitous meeting with my faculty mentor. And I said, I just want a backup plan just in case. And do you have any ideas? And she said, well, have you heard of this field called developmental behavioral peds that nobody seems to know about and nobody wants? And I go, interesting. And so there was no Google back then. And so I think I went to Alta Vista or some sort of search engine, and I typed developmental behavioral pediatrics. And the first thing that popped up was a little website called dbpeds.org. So I clicked on it and I scrolled to the bottom. It said, contact us. And I called that phone number, just blind called that phone number. And it was a doctor in Tampa, Florida, Hank Shapiro. And I said, Dr. Shapiro, you don't know me. I'm a pediatric resident in Chicago, and I've heard about this field from my mentor. I don't know anything. And your name came up. Can I come to Tampa and I observe with you? And he laughed. He said, why would you come to Tampa when you've got great people in Chicago? I said, I didn't know I had great people in Chicago to go with. And he put me in touch with the University of Chicago and Dr. Roizen. And so I reached out to her and said, I don't know anything about this field. I just want to do a rotation. I just want to look. She said, come on over. I did a month there. I was so hooked that I ended up doing 4 electives in developmental behavioral peds. So I finished my pediatric residency without ever doing, and don't tell anyone, pulmonology, gastroenterology, anything else. I just did. And my program director goes, I know what you want. I did one at Lurie, I did one at Rehab Institute, I did one at U of C, I did one at Cook County, I did one, and I go, I'm done. And then when it was time to interview for fellowship, and I went around these different programs, it was perfect. And I have not regretted it one bit, because I would have been a lousy hematologist, oncologist. My personality suits better for this. But it's never too late to make a decision. And I didn't come with a clear path to there. I just sort of backdoor. But the key to my story is the right mentors at the right time can change your life.
Okay, excellent. And Talia asked us what you guys just answered. So Talia, hopefully we nailed that one down for you. So you gentlemen were kind enough to put together a brief slideshow for us. Give me 1 second here so we can start running through that. Okay, guys, take it away.
Well, Neil already alluded to the fact that there is great job security, and let me give you a little bit of a sense of what he means by that. 25% of kids have a developmental delay or a mental health problem, so 1 in 4. And there are 706 board-certified developmental behavioral pediatricians, at least board-certified in 2020. So that's an incredible amount of kids for us to conquer. Now, to give you an idea or a relative perspective, if we're talking about pediatric cardiologists, only about 1% of kids have a pediatric cardiology problem. But there are about 2,600 pediatric cardiologists. So in order for us to have the equivalent number of coverage for developmental behavioral pediatricians, we'd have to have about 65,000 developmental behavioral pediatricians to provide the same level of support. There is job security in what we're looking at. Why don't we do the next slide?
Okay.
And you alluded to this being the best kept secret, this field, and that's why we wrote an article that was just published in the Pediatrics Journal called Defining Developmental Behavioral Pediatrics. Our field is difficult to define, and it's difficult to define for a number of reasons. The biggest reason, I believe, is because our services integrate with the community. We don't treat them in isolation in our clinic. We work with therapists, and we work with schools, and we work with hospitals, and we work with community service and parent education organizations. And because of that, every state, every county, every city has different services available. Not only that, there's access to autism services, or there's access to early intervention services at different levels in different locations. And so how we practice is a little different in each state based on the services that are available. So we wanted to come up with a common definition so that parents really understood what we can do, so that payers understood what we can do, so that medical students who are trying to figure out what they want to do know what we can do. And the definition we came up with, and I'm going to read some of this, is developmental behavioral pediatrics is a board-certified medical specialty that cares for children with complex and severe developmental behavioral problems by recognizing the multifaceted influences on the development and behavior of children and addressing them through systems-based care, and with a neurodevelopmental strength-based approach that optimizes functioning. So we see kids from the time that they're very young to the time that they're old, to the time that they're entering adulthood. We think about the family environment. We think about their educational opportunities. We think about how the brain is developing over time. And that to me is when I was talking about looking for clues, I love sitting in a room with a patient for 2 hours and being able to kind of Sherlock Holmes this kid, look at what's going on at school, what's going on in the environment, what are they seeing, how is that child sitting, what is their posture like, how are they moving, what do they do when I get close to them, do they make eye contact when they call their name? I'm looking at all these clues, trying to figure out what goes on with my patient. So we published this article to give a clear sense of what we do, and it's available. There's the link if that's something that you want to learn more about. What do we do? Next slide. Neil, I think you were going to talk about this, right?
Yeah. So again, as Dr. Korb pointed out, there are many different things we learn to do. And when you practice, there are many different things we can do. We can choose to do all of them, some of them, one of them. So commonest to most of us is going to be clinical care of children and adolescents with developmental behavioral issues. This can happen anywhere. The other reason why we are so valuable in general is we don't need I have practiced, I kid you not, from major academic centers to tiny one-room and two-room places in rural areas. I have been with zero resources and I can still function. I can have big testing kits and lots of resources. And so the thing is, everything is in the training and in your mind and the way you've learned. Your skill set can be applied. I have practiced in schools. I have practiced in early intervention centers. I've practiced in standalone institutions. So clinically, you have a skill set that could happen anywhere. You could work anywhere. You just need your brain and you need a computer, unfortunately, because of the electronic health record. But back in the day, you needed a piece of paper and a pencil. So it is what you want it to be, but clinical is the bulk of what a lot of us do because, as Dr. Korb pointed out, the demand for us is so huge. I mean, there are states in this country, we won't name them, but there are states in this country without one of us, which is mind-blowing. When I did the math, there's one of us for 500,000 kids. And so the issue is, can you imagine how long it takes to get in to see us and the amount the parents want their children to see somebody like us? So clinical is never going to go away. We have to do it because we support the patients, their families, and the primary care providers. Teaching is a huge thing for some of us because we're either in academic institutions, and even if we're not, like Dr. Korb, he's affiliated with Stanford. He teaches, even though he's in private practice. Fellows can come learn from him. Residents can come learn. I've always been part of curricular development with medical schools and residency programs, but it's beyond that. So I have taught engineering students, psychology students, I have been mentor, preceptor. I've been on their dissertation committee. So the skill set we have can go beyond medicine. And so it's important to think that you are valuable to a lot of different disciplines. And you say engineering. Well, there are a lot of engineers who are interested in helping the fields of developmental disabilities, developing technologies, but they need to pick our brain because we know those patients. So teaching can be not just medical education. And research. There's so much more to learn about these populations, about the way the brain functions, about genetics, about educational interventions, about medication intervention. So research for many of us is a huge thing. And then advocacy. So what I do is I do stuff at a state level, I do stuff at a national level, because there's still inequity. There's issues where not everyone gets the same access. And it's our job to make sure that equity comes into play. It's our job to make sure legislators and powers that be understand. I write letters to senators. I've testified in front of the state legislature. Right now, the governor of my state has appointed me as the sole pediatrician to oversee autism access in our entire state, because they realize that we understand the issue and we bring the medical perspective to it. And so there's a lot of opportunity to take a prominent role in whatever form you want. So there's a lot of things we do, and you can do any of it, and you can find a job that will let you do any of it if you just make your case, go, I want to do this. And the fact that you're needed, they go, fine. Next slide.
So I wanted to talk about this. If you can see this slide, to give you a sense of what the range of kids and cases and things that we see. A lot of times people just think about a developmental behavioral pediatrician and they think about autism. In autism, we do see a lot of kids with autism, and we know that the incidence of autism is growing tremendously, 241% over the last 22 years. Now 1 in 44 kids is reported to have autism. But we don't just see autism. We see ADHD, and we see aggression, and we see behavior issues. We see adoption and foster care issues, anxiety, depression, obsessions, compulsions, tics, constipation, bedwetting. There's a whole range, cerebral palsy, kids with motor delays, language delays, just kids with temperamental issues that parents don't understand, kids that have experienced trauma, kids with visual impairment. There's just a whole range. And I appreciate the breadth and the variety of what we get to see. And you know, we don't see these kids in isolation. If you see a kid with attention problems, you have to be thinking about all those medical things. And Neil, I hope you didn't miss too many courses because you know, we need to be thinking about if they have a medical issue, how is that affecting their attention? How is that affecting their behavior? If they're a person who's non-communicative, non-verbal, you know, could they have ear infections and other medical issues, toothaches that are causing their behavior to go awry? So we have to tap into our medical knowledge as well as you know, all these other things that we tend to see. I tend to, whenever I speak with teachers or with parents or with doctors, I say that I may not be the smartest person in the room, but I'm the broadest trained person in the room. And I because of that, I'm really good at telling you what this is not, and I'm really good at telling you if this is a problem or not. And it's very different than if I was a psychologist who specializes in dyslexia, because they can be great at dyslexia, but if it's not quite dyslexia, they may not know what to do with you. So I really appreciate the broad training that we get as a developmental behavioral pediatrician. And when I sit in the room, I get to lead a lot of those meetings because I can listen and hear and understand all those different fields.
And Kyle,
go ahead, Neil.
Yeah, Kyle, I think, you know, somebody in the chat asked what's the difference between DBP and psychology. And I think, you know, what Dr. Korb alluded to, we've been trained by all those specialties, right? I've had incredible psychology, psychiatry, genetics, neurology, special education, speech therapy, teachers and mentors. So we imbibed a little of everything. So I always consider myself a jack of many, many trades. I'm a master of a few, but I'm a jack of many trades, which means I can speak a common language to a lot of disciplines. When I speak to a psychologist, they're always impressed that I know so much about psychology because they've not seen physicians like us. When I speak to a geneticist, they understand that we know enough about genetics to be dangerous without being totally clueless. And so I think that that broad understanding makes us very appealing in terms of interdisciplinary teams, because we have the respect for all the other disciplines, and we also have just enough knowledge to challenge them and push them and make them see different perspectives. So it's really valuable to have that broad training.
Sure. Neil, and I would add neurology and psychiatry too.
Yes, all of the disciplines. And we'll come to it later, maybe in the Q&A, but there are differences, and the article speaks to that, in the training pathways to reach there. To get to be a pediatric psychiatrist is a different pathway than a developmental pediatrician, is a different pathway than a child neurologist, is a different pathway than a neurodevelopmental disabilities physician. And those are subtle things, but at the end of the day, we're more alike than we're different. We're all physicians, other than the psychologists, but we all take care of similar types of kids. We come from different perspectives. It just depends on your philosophy of how you would like to learn. Nothing against the other specialties, but to be a child psychiatrist, you have to go through adult psychiatry to child psychiatry, the same with a child neurologist. I hate adults. I'd rather not work with adults. So I chose the specialty that takes me through a pediatric pathway because I didn't want to hear whining and griping about it. But guess what? I have to now, because the parents of the children I deal with are whining and griping adults. And so I resigned myself to the fact that I found the pathway, but the end result is the same, and I'm okay with that. But you know, you can choose the pathway that suits your personality and what you wish to desire, but you can be competent in taking care of children with special needs no matter what your pathway is. It's just that there are a lot more child psychiatrists in this country than there are people like us. So for example, in Michigan, I believe there are and Michigan, well, we're lucky. We have 12, which is shocking because there are some states with 1 or 2 or 3, but there are like, I think 67 child psychiatrists. So there's always going to be a mismatch. I think it's important to recognize the training pathways, the job opportunities, and just the style of practicing.
Neil, let me put a little bit of a counter argument to what you just said too. I agree that there's overlap between what we all do, but I think as a developmental behavioral pediatrician, we practice a strength-based model much more than any other specialty, where we're looking at their strengths and weaknesses and realizing that their strengths in life are what are going to get them the successes that they want. We're not just looking at the weakness and trying to fix them. We're trying to figure out how to balance those two things. And I think that's unique about our specialty. I also think, if my child had schizophrenia, I would go see a psychiatrist. But if my child had attention problems and was struggling at school, I think I have much more experience working with systems than that psychiatrist would. And if my child was having seizures, I'd go see a neurologist before coming to see me. But if my child was having a delay in their speech development, I think we could help that probably more than the majority of neurologists. So there's some differences. And, I don't hate adults as much as Neil does, but I really relish the role of being an interpreter between kids and adults, teaching kids how their parents think and teaching parents how their kids think. Why don't we do next slide?
So this little top 10 reasons, you won't believe how well this has aged. I wrote this in 2011. I kid you not. I wrote this in 2011, and I wrote it. And if you, and we, Kyle, we can share. I'm not going to read everything. We can share this with the audience and stuff like that. But I wrote, telehealth into it because I was doing telehealth way back then. Number 4, I was doing telehealth 12 years before COVID. And so we are perfectly positioned. We're one of we pivoted. I saw a patient on March 17th, 2020, when everybody was hunkering down at home. I was at home with my laptop open, the VPN, and I had not canceled a single patient of my schedule because I went straight to telehealth and I saw them all in their home.
Yep, me too. Same thing.
Yep. Very few specialties can say that. And that's what the patients appreciated because everything was shut down. Every clinic, every hospital. I was at home, they were at home, and I did everything I needed to do. So that was great.
Can I add that with that pivot, because we are a systems-oriented specialty, being able to view their home and being in their home was an added bonus. In some ways, it made what I was doing even richer for some of my clients because I could see whose house was chaotic and whose house was disorganized and where they were able to control their own child in that environment and where they weren't. So it was really cool to be able to do that and have that access.
The other thing, Kyle, is number 6. I have not had a beeper in 20 years. I have not done anything after hours. I have not been in the hospital after hours at all in 20 years. You can choose to have the quality of life and work-life balance because we don't need to do those things. I don't do inpatient consults. I don't do after hours. I don't do emergency room. I don't round on weekends. That is one of the great privileges of our field because it is not because because we are at our best in an environment that is friendly to families. And whenever people go, we have a child in the PICU who needs, and I go, you think I can really assess his behavior and his development I was once called to check on the behavior of somebody who was sedated and intubated. And I wrote a 1-line, unable to assess behavior, child is sedated. And they're like, oh, we didn't think about that. And so, the bottom line is the quality of life is incredible. Job security, we talked about, flexibility, we talked about, and you are so loved by families because you give them hope and you talk about things when everybody else has written them off. People think about individuals with disabilities and complex behavior as impossible to deal with, or they wouldn't. And we're the ones who sit, we listen, And we provide, and even if we don't provide cures in some condition, we provide guidance, hope, and a pathway forward. And the most important thing, because we're so few of us, we have a very tight network. I was telling Kyle just before this call, if there are any students who are interested in doing, say, an elective or observing with the DVP around this country, between Dr. Korb and I, we probably know every single one, or we know them with 1 degree of separation, because we've either trained with them, taught them, or worked alongside them in the last 20 years that he and I have been practicing in different parts of the country, right? And so we can connect people, which is more than can be said for some specialties where people don't know everybody. We pretty much know almost everybody.
Neil, I do take call. I have a busy clinic. I've got 5 therapists, a couple psychologists, and I get called about 1 call every 2 months. That's my call for my busy clinic.
And see, Kyle, as you can imagine, we both are trained the same way, but both have the same certification, and we have different practices. And we and that's the flexibility. If somebody on the call wants to have a private practice like Dr. Korb, that's great. And somebody wants to have an academic, that's the great thing about what we do. You could tailor your career based on what you want to do in your life and how you want to do it. Next slide. So this is a really important thing for students out there. Our society has done a wonderful job in inviting first pediatric residents and now medical students to come spend a few days with us at our annual meeting. And it's the application for this should be open anytime now in May. And basically, it's an online application. You submit why you're interested in attending our meeting. You have like a reference letter, this and the rest. And it's a little competitive, but we will pay all expenses, including hotel, flight, and registration for students and residents from all over the country to come to our annual meeting, mingle with us, meet with us, be assigned a mentor, attend sessions at no cost. We started this a few years ago. We had about 23 candidates before COVID. And then when COVID hit, because there was no travel involved, we jumped that up to like 30, 40 of them. And
I think even 50, wasn't it?
Yeah, 50 something. Now we're back in person. We're going to be in Denver, Colorado. So it may be only 25, 30 again, but students can apply. So if there's somebody interested and they apply, they might get a chance to see how we operate they can talk to us, meet us, see the sessions, learn about things. We have special sessions for students. We assign them mentors. So it's a great opportunity. And I don't know too many societies which do this, but it's a great thing for people to learn. There are only caveats if somebody is already like a resident has already applied for fellowship. This is not for them because this is for somebody who wants to explore it, not somebody who's already committed to it. So, I'll be happy, Kyle, when the link goes live to send it to you if you want to post it to people and they can decide if they want to apply. Next slide. And that's it because we love to answer questions. We've put a little bit of the social media things and the little QR code links to our society. So Dr. Korb has been the president of our society a few years ago, and I'm currently on the board of directors of the society. And we are responsible for furthering the mission of the society as it applies to clinicians across the country and the world. We have lots of international members in furthering the care of children with special needs and their families in an we have not only physicians in our society, we have all sorts of disciplines. We have nurse practitioners and physician assistants, and we have psychologists and special educators and speech therapists. We have general pediatricians. So a lot of people flock to us to learn more about how they can help these families because we realize there are not enough of us to go around, so it really takes a village.
And that, again, that highlights that unique thing about our specialty is that we are working with the community. I don't think if you went to a cardiology, not to pick on them, or a surgeon or a whatever conference, you wouldn't have all of those other team members there, but they come to our meetings and we learn from them. We learn what they're developing in the field of education and what they're developing in the field of psychology, and we use that and share what we know from our fields.
Okay, well, excellent. Thank you for running that down for us. And I just want to jump into this. Talia has an excellent question here. What would a typical appointment with a new patient look like?
Damon, you want to take that? Because again,
Sure.
we're very different in how we do stuff. So I'd love to learn how Damon does it.
I'll tell you how I do it, and I know for a fact that how I do it is different than how others do it. For me, I spend about an hour and 45 minutes with my patients. They fill out forms beforehand. I review all that information before they come in. They send in any prior testing they've had from their schools and their report cards and as much information as I can get beforehand. I review. And then they come in, I spend an hour and 45 minutes with them. And my appointment starts like this. Johnny, you and I are going to talk. We're going to talk at first. While we're talking, there's no playing with toys. As soon as I start getting bored of whatever you're saying, I say with a smirk, and then I'll start talking to your parents. And at that point, you're welcome to play with all my toys. You can play with anything in here. And if you're bored of these toys, I got other toys you can play with. And then I talk to the parents. I also say, mom and dad, if at some point you want a separate adult conversation, that's fine. I'm happy to do that with you. If you want to all talk together, that's okay too. And then we spend most of our time talking. Now, if the child has certain developmental delays, I might take them over to my desk and do some neurodevelopmental screening where I look at how their memory works or their sequencing skills or their spatial skills and how that impacts how they write or read or draw. If I'm worried about their social cognition, I may do a test called the ADOS, an Autism Diagnostic Observation Schedule. I may do some of that. But most of my appointments are talking. And I would say after an hour and 45 minutes of time with the patient, 95+% of the time, I'm pretty confident with my diagnosis. And maybe 5% of the time I say, you know what, we need to come back and do some testing with our psychologist, or we need to come back and do some testing with a speech pathologist. But that hour and 45 minutes, I've got a pretty good clue what's going on. And I'm guessing that's different than how you do it, Neil. And I'll let you go first, and then I'll tell you about another doctor who's down the street who does it totally different than I do.
Yeah, so it's a little different. I do 60 minutes. I do get a little bit of information ahead of time. And I've sort of over the years tried to really rapidly multitask when the patient's in the room with me. So I'm sort of asking questions, writing one eye on the kid and what they're doing, pausing my questions, interacting with kids. So I do believe I have untreated ADHD, and Damon can attest to that. He has seen me in action. But I use it to my advantage because I can rapidly multitask. Now, I don't get everything complete in that 60 minutes. It's part of my problem. But I am rapidly getting a lot of information. I am talking to the parent, watching the kid, and reading their school records all at the same time. And what I'm doing, I'm trying to prioritize what is it that they need the most in that period of time, and then I decide what direction I'm going to take. It's more fun for me than challenging because I'm always learning something new. Today, I saw a little 2-year-old that for the first 15 minutes, and Damon and I have done this enough, and he can attest to this, that we know mostly when we enter a room what we're dealing with. Yes, it's important to get the history and stuff, but we have a innate instinct based in very good training that we sort of know in direction. And this girl,
I call that elevator door diagnoses.
That's right.
The elevator door is open. You go, that child has this, and the elevator door's closed. And it's because just like again Sherlock Holmes, we learn to look at those clues real instantly. How are they standing? How's their posture? How's their eye contact? What sounds are they making? And it's really fun.
It is, and what makes this so great is today I was thrown the first 15 minutes and I didn't get a read on her, and I go, this is unusual, not impossible, it's happened before. And I go, I'll be right back. And I went and got some more toys. Now, I don't have the depth and breadth of toys that Damon does because I'm in an academic center and I have a little bucket of Legos with one ugly plastic dog and one dinosaur. And that's all I have. And I make do because I can get everything I need with the absolute minimum stuff, right? And only when I brought that up and I started doing things my training taught me to do, I started teasing out what she does and does not have. And by the end of the 60 minutes, I was okay. Because then I was like, all right, I got it now. But the first I was like, wait, it's this or it's this or it's this. And that happens sometimes, but that's what keeps me on my toes and humble. Because if you get into the hubris of what's going on, you're going to fail. Because these kids are too complex and too smart for you, and they can trick you. I've had kids that I'm doing the ADOS and I don't really get it till later on when I'm scoring it, because in the room I thought he was one thing, and when I scored it I was like, okay, he's different. So that's amazing to be challenged. But yeah, and I do a lot of medication management, which goes quicker, which is, how do you do, what you got, let me see your report card, let me see what's going on, bam. So you can have any type of visits you want. You can see new patients, you can see medication only, you can see autism only, but the flexibility is all yours in the field.
But Neil, with that being said, the academic center I trained, and like I said, the clinician down the street, they often do day-long or 2-day assessments. They might come in and where I trained, the physician would see them, the psychologist would see them, the social worker would see them, and it would be hours. Then we'd break for lunch and we'd all meet and discuss them. The guy down the street will spend an hour and a half, 2 hours with the parents. Then we'll spend an hour and a half, 2 hours with the kid, and then we'll spend an hour and a half, 2 hours kind of debriefing the parents about what they learned. So there's different ways to do it. I think I'm, like I said, 95, 96% accurate with my hour and 45, and I know those 4% that I need to do more on.
Yeah, and you know what?
Save them money.
You're absolutely right. Part of the problem, so I trained in a model like that, right? But I disavowed it pretty quickly once I went into practice, because I realized I'm not doing any family any favors by keeping them hours on end. The child gets more fatigued over time. You start becoming redundant. And so I've sort of began to embrace a model. Plus, it's the business of it, right? There are academic centers where business is not as important, but I was early in my career. I was taken aside and go, you're not getting 2 hours. And I'll never forget that conversation. It was a new faculty. I go, I'm used to 2 hours. They go 30 minutes. I go 90. They go 60. I'm like, done. And that's 20 years ago. And I have...
So Talia, did we answer your question? What would a typical...
Sorry, Talia. It's just Damon and I know each other long enough that we could just go at each other for a long time, all in fun. But yeah, so Kyle, at the end of the day, it's as variable and as flexible as it needs to be. But yeah, I think you have more questions. This could go on.
Right. So we got another good one here from Ambrose. Whoops. Okay, I figured out how to click buttons correctly again. What does DVP Research look like?
Damon, you okay if I start with that?
No, you'd be better at this than me.
So this is, again, as variable as it needs to be, Ambrose, because so it's funny you ask that. DVPs are incredible at being accessible, available, and ideal as team members in almost any sort of research you want. So I'll give you a brief synopsis of the type of research I've done. And please, nobody laugh at me, because I did have somebody laugh at me when I told them my research. And that gentleman said, and I quote, "You have no focus in life. You're never going to succeed." And I go, "Thank you very much, Dr. XYZ. Because this is what my research is, and it's as varied as it needs to be. I have done research with engineers on developing novel technology for use in kids with disabilities. I have worked with pharmacists on looking at the practice of medication management as extracted from the electronic health record. I have worked with community organizations and health service researchers on how telehealth can improve access to communities of populations that are generally underserved or have non-English speaking patients. I have worked with basic scientists as they look at particular types of molecules and what sort of different lab work can be. It's because I make myself available to a variety of researchers, and they know my interest, and I love learning from them. And I never let geography be a barrier either. So all my collaborators are around the country and around the world. I have published and done research with people from India, Singapore, everywhere in the United States right now. And I've been doing stuff with law enforcement also. So right now we have a grant with a police officer and people who work on the edges of school violence for children with special needs, and how they're exposed to violence and how they commit violence and what schools can do. So I have a very diverse research career. That being said, I have amazing colleagues who are uniquely focused. Abha Gupta in Yale does incredible work in autism only and the genetics of autism. Some other people at Stanford do incredible work with ADHD, right? Damon, there are people in our field who are fantastic in learning disabilities and Down syndrome and things like that.
Yeah, I would just add to that, just thinking, Neil answered very specifically. I would say, the types of research I see is we do a lot of preventive care. We're big advocates for early intervention services. So there's a lot of public health related research. I think we see a lot of imaging related research. We see cognitive screening tools, and we see medication research, and we see a lot of intervention based research. What works, what doesn't work.
Okay, excellent. So we had some questions that we teed up, but the ones we're getting are better. So Talia asks, what are some unique challenges of DVP versus other specialties?
Talia, I would say the primary thing is time management, particularly vis-a-vis depend. Now, Damon might have a different answer because he's his own boss, but I answer to a boss, and it's always that push and pull of how much time are you spending? How much time do you need? Is that in the best interest of the organization? Sometimes that's at odds of what's the best interest for the patient. So I think documentation, we're trying to get better. Historically, I was taught, I'm sure Damon was too, big, fat, comprehensive reports, right? Very detailed stuff that will help families. Yes, and that takes time and effort, though electronic health record has been trying to, make that more automated. I think other challenges, real big challenges, are reimbursement. Part of the reason to publish that article was to make payers realize the value of what we do, because traditionally they have underpaid us or for our services because we are not procedure heavy. We're not cutting people open and transplanting organs and doing things. So they have valued those services much higher than us trying to help a family with a child with special needs, negotiate schools, etc. So that has been some of the challenges really in terms of practice. The other thing that at least you guys, and I won't shy away from it, salaries and compensation has been lower for our field than what it should be. And that has been a deterrent for some people, that they compare it, say, to an allergist, immunologist, or a cardiologist, and there's different. But I always counter that and say, think of the work-life balance, think of the flexibility, think of what you could do and the job security. Only you can tell if that is worth it. But that is, I'm only speaking as an academician. Damon has a different answer for that regarding compensation as a private practitioner, and it's important to hear his perspective.
Right. I think part of the reason our reimbursement is so low is that we aren't good enough businessmen. When there's 706 of us and there's a need for us, there's a supply and demand, and I think there's an opportunity to really work that. I have done like many child psychiatrists have done and gone into a private practice where I'm fee for service. And I do very well financially, and that's an option because the demand for what we do is so high. But I want to run with something that Neil said earlier. We're not procedure oriented, true, but we are life changing for families. Teaching them to appreciate the strengths in their kids, and teaching them to have the perspective that just because they're not there yet at age 8 doesn't mean they won't be there at these parents come in thinking their kids are going to grow up and be axe murderers because they're, screaming and hitting the kid next to them at age 8. It doesn't necessarily mean that. And we can change their lives, as well as get kids into intervention services who have autism and other developmental delays. It impacts their entire being and their entire life, and the way their families view them, and the way the schools view them. So it's really powerful what we do. But I agree with Neil. One of the barriers or one of the challenges in our field is the amount of time we take versus the amount of money the hospitals want to reimburse us for that time.
Interesting. Okay, Talia, thank you for that question. Next one. From Tiara, how closely, if at all, do you work with patients' schools? How well acquainted are DVPs with special education law?
Oh, I'll go
So
first.
Damon, be very careful how you answer this question, because the individual asking this question is an expert in the question. All right. So I am going to let you fall into this trap.
So
Sorry, Tiara.
this is what I'd say. Every month I sit in on an IEP meeting. I go to the school, or now it's been much easier with Zoom, but I attend IEP meetings, and at those meetings, I think my opinions are very valued, because I can offer things that they can't offer necessarily. I am familiar with special education law, and I either refer people to advocates, or I provide the counseling and the advice and the support myself, because there are federally mandated services that are available to these kids that somehow get overlooked at times by schools, and or unfortunately they don't have the resources, but that's not the child's fault, and so we advocate and support them to figure out what they need. I would say, Tiara, that I work very closely with schools, and not in an adversarial way, by the way. I don't think I come in the room and they go, "Oh no, we're in trouble. Dr. Korb's coming." It's very collaborative.
That's true. I think it also it goes back to the training. So part of my training, I spent all 3 years of my fellowship in 2 schools. I spent my entire 3 years, 1 day a week, embedded in school systems, and I learned to appreciate and learn from special educators, from principals, from teachers, from paraprofessionals. One was in a completely special need school for kids with cerebral palsy, and one was in a regular elementary with a lot of impaired kids in Baltimore City. And so not only that, we got taught. One of my teachers was a special educator. We had school psychologists as our thing. So we had to learn the process, and we learned it. And we learned it well enough that I feel completely comfortable. The thing is, I'm trying to train my trainees, my residents, my medical students, that the IEP, the educational documentation, is a critical component of the treatment plan. You cannot be a physician in our field and not understand the other systems involved. You have to learn to read the documents, interpret the documents, sometimes tell the parents what it means, because sometimes they don't pay attention in the school meetings. They're overwhelmed, they feel, and you're there to be that guide and interpreter, and they appreciate it. And often it's something that, and as Dr. Korb mentioned, you can provide feedback, particularly if there are medical issues. I use terminology in that shocks school sometimes. They're like, how does he know what a manifestation determination is, this MD? And I go, you don't know much about me, do you? And so the training is there, the experience is there. Some of us have had more than others, but we always respect, the people who really understand it, who do it for a living, like Tiara. And so, that collaboration exists. I know enough to be very comfortable in a school setting. But I do know that I don't know everything, and I try and keep on top with whatever the new reauthorizations are. But I think more than any other specialty, won't you agree, Damon? We understand school processes and documents more than probably any neurologist, psychiatrist out there, except for our school psychology and some of our clinical psychology colleagues.
Agreed.
Excellent, Tiara. Thank you for that question. And we're coming up on time, so I wanted to get into wrapping up a little bit. So in your position now, knowing what you do, what would you say to yourself back when you started out on this journey of becoming a DVP?
So for me, I think I have the funnest field, the funnest job. I play with kids all day. But it's fun for me because that's what I like to do. I like to play with kids. And, whether you're on a journey towards being a surgeon or you're on a journey towards, being a psychiatrist, it's really what is fun for you. And this is fun all day. I'm teaching parents, I'm educating, I'm changing lives, and I'm playing with toys.
And I would go back, 25 years and say, this is the right decision, because I've not regretted it a minute. At the time when I was sort of halfway between HEMONC and DVP, I'd go back and go, never look back. And I'm glad I didn't. I think this is the best thing I ever did. And I just love everything I do. Of course, there are days when you go, but no, I would say this was a very good decision. And I thank my mentors for it.
Excellent. Thank you. And do you have any closing thoughts for the audience?
I just want to say I want to thank SDN for allowing us to be here and share our perspectives. I think I love the questions from the audience. I would encourage them, please reach out to either one of us if you want any further information. If you want to be connected with the DBP anywhere you are in this country, in Canada, anywhere around the world, we can make it happen. We can facilitate an email introduction, and then you take it how it goes. If you want to keep your eyes open to the SDBP website and apply and show up at the, get selected and show up in Denver, we're happy to introduce you to others. My greatest thrill is to bring new people into the field because you are our lifeblood. You will keep it going long after I'm decrepit. Damon will never grow old. He has not changed at all in 25 years that I've known him, but that's all I have to say.
And I would say you could find me on Twitter or you could find me on LinkedIn. And if you want to reach out, and we'll get you connected to people in your area because we need you.
Excellent. And Talia, Ambrose, Tiara, thank you for those questions. Check out our social media. I'm going to put that back up on the screen real quick. I'm going to make sure that we post that article that we referenced earlier, as well as a link to applying to get to have an all expenses paid trip to come hang out and get mentored into the field. That sounds like a pretty good deal to me. So I want to say, again, thank you so much, Dr. Korb, Dr. Soares. I appreciate your time and getting to learn about your field. As a pre-med who's applying next year, it's nice to hear about a field that didn't make me want to run to the hills like some of them that I've learned about. So again, thank you so much for your time and doing this for us. Kate says thank you as well. Very much appreciated.
Thank you, guys.
Thank you very much.
And thank you to everybody tuning in.